Specifically, we want to start covering eating disorders. I want to go over some information on eating disorders. So we have that in general because it's kind of the critical part of what we're talking about. You're going to see people with eating disorders and many different issues related to them. Just in general, it's going to be a very common thing to kind of see. And so just kind of covering it a little bit. Real life-threatening illnesses, potentially fatal consequences. Eating disorders are really serious. And by the way, this PowerPoint is on Blackboard. But it is, you're going to see people with eating disorders sometimes have very complex types of symptoms. Those who are bulimic, things like that, a lot of them conceal. I've worked with teenagers who, under their bed, mom just found Tupperware containers full of vomit that they had stored for weeks and months, trying to hide from mom what they were doing and things like that as well. A lot of these disorders can have severe health repercussions as well. For example, hair falling out, losing teeth, organs shutting down, and organ failure. So these things are common and part of your intake when you're working with eating disorders. One thing I'll tell you up front, if you're going to work with people with eating disorders and you don't specialize in it, get the training you need, get the supervision you need, and then work with somebody closely who knows what they're doing with eating disorders. So at my practice, we have one of the nation's leaders in eating disorders that works in my practice, and she has a waiting list for like 3 or 4 months, and people come as far as Richmond. People drive from Richmond every single week to get treatment from her. And so you can imagine, an hour and a half drive one way to get therapy because she's effective with eating disorders. In your clinical work, whatever you specialize in and you get trained on and you really learn how to treat, you will get known for, and you're going to be able to build a clientele based on that. Yes?
Is pica considered an eating disorder or an addiction?
It's covered a little bit differently. It can come in more of an OCD type of thing than it is necessarily an eating disorder, because it covers a lot of different, pica gets into a lot of different types of behaviors that are more self-soothing and random, but although it involves eating, but again, and we'll get into that too. And you're going to see you'll see pica every once in a while. You'll see things that are kind of off and specific to certain things. But let's talk about the eating disorders specifically, though. Again, it's very, very extreme behaviors and things that go with it as well, as far as emotions, attitudes, behaviors. And it's caused by a range of biological, psychological, and sociocultural factors. There's a lot of factors that kind of feed into eating disorders in general. It affects everyone, all ethnicities, sexual orientations. There are severe eating disorders among the gay population. There are some in children, adolescent, every single population. You'll see everything in all of them. As many as 20 million women and 10 million men will struggle with eating disorders at some point. So eating disorders is something that will affect people in many, many different ways as well too. So some of the biological factors are here too. You have your family history of dieting, type 1 insulin dependent diabetics, genetic predispositions. You may see some of these as well. With overeating, which is also a maladaptive eating issues as well. There's a strong genetic part to that. They say that, and then other people say it's about 20% of the issue is genetics. So while there is a predisposition, some of that's learned. A lot of that we see in personality. Did they learn that from somebody, or are they modeling behavior? With eating disorders, you're gonna kind of attack it from all different angles, because you could have any of those types of factors. You could have something, a child has learned from observation, or maybe they have an inaccurate, unhealthy view of their self, or their body, or even body dysmorphia type of things, or those type of issues. So you're going to look at all those type of factors to put together, a picture and just kind of a view of why people are acting the way they are, specifically with food. Psychological factors, your low self-esteem, relationship with self, which we just talked about, feelings of inadequacy, depression, anxiety, fear, or loneliness. You'll see a lot of those. You'll see a lot of anxiety, people eating because of anxiety. You have to remember things that are addictive and things that can be affect you in those areas are all related to brain chemicals. So we have 60 psychoactive drugs in our brain. And when we get tired at night or I get boring, the depressants start to come in, you start to get tired, those type of things, or, right after you carb and eat a meal, you might all of a sudden start feeling tired. That's the brain's reaction, where, you need those 2 cups of coffee before you came here, that was to crank up some of the stimulants in your brain. It's not that caffeine itself makes you energetic. It's that caffeine activates what's already in the brain. So a lot of drugs people use for abuse and things like that, they manually adjust the brain chemicals that are already there, that God developed right into the brain to help us regulate our lives. You get a great grade on something and you get serotonin, dopamine, and you're like, yay. That's the brain's way of acting. And so people tend to try to manually adjust those from time to time. In other words, they'll get into adjusting their brain manually by food. You'll find it by sexual content, things like that. Pornography is often a brain chemical. It's a way of releasing dopamine and different chemicals in the brain that come through sexual contact that can be done without a partner. And so often you'll see couples kind of come in and, one party might feel really betrayed and the other one might be really just trying to cope with stressors and figure it out. I can manually adjust the brain chemicals in my brain and feel better when I want to feel better. And so there's an unhealthy coping, and that's where you kind of get into some of these disorders too. Yeah, do you have a question?
Yes, the type 1 diabetes, that's kind of interesting. Do you think that would be linked to like the hormones or more like the strict regulation of like when to eat so the insulin doesn't drop? Like what would that?
Yeah, I think it's more the strict regulation. Again, if they're afraid of the diagnosis, and diabetes is a wicked disease. So if they're kind of like, hey, I got to get a handle on this then what they can do is they can start trying to regulate their eating so much that they're trying to really trying to kind of overshoot the goals of maintaining that in a healthy way, and they can go the other direction with it. So social factors, cultural norms that overvalue appearance. These type of things are kind of critical. It's funny because you look at these magazines, you look at media, and you think, well, I don't look at that person. People hold themselves to those standards. In marketing and things like that, there's actually like you'll see a girl in a picture and she's holding her hand like this with a ring. Often the girl's hand you see is not the girl in the picture. They liked her face, and they have a hand model that it actually is her hand. Like she wasn't even pretty enough to have like represent the jewelry she's selling. So it's super. And if you go through and you look at all the stuff that has to be done, the touch-ups, the retouch, the removing part of the face, the making this, that person doesn't look like that either. But we hold ourselves to these standards, and it can be super unrealistic. It can be really complicated. So body dissatisfaction is a big one. Drive for perceived ideal body type. Historical trauma, again, people can try to treat trauma with what they can control, and they think I can control my eating, I can control whatever. And so you'll see people sometimes in gyms, and there's one person at the gym I work out at where she'll be on a treadmill sometimes we'll see her almost every day we go there, and she's on the treadmill for at least 5 hours, maybe a day, solid. Because she'll go, somebody else will come, a friend come, we'll do something else, and we'll end up at the gym for several hours, she's still there, and then, somebody else, it just, who knows how long she stays there. And so it's constantly trying to achieve whatever goal she has. But it's beyond being healthy. It's a point to where, trying to get more out of it than that. Yes?
I know there was a time a few years ago where women were trying to get the gap between their thighs. They don't want their thighs to touch. And so they were going through a lot of strenuous things, just trying to get that open space and want their thighs to come together.
Yeah, I mean, it's ridiculous what body types people try to achieve, and it's one thing to be healthy and have healthy habits. It's another, and view yourself in a healthy way. It's another thing to so hate yourself when you look in the mirror that you try to restrict, and different things like that. So, but people with eating disorders look healthy and may be extremely ill. You may look at them and think, "Ooh, they look healthy." They may get a lot of reinforcement. They may get a lot of attention from people thinking, "Oh, she looks beautiful. Oh, she looks like," and at the same point, they're getting all this attention, and what gets them to maintain that can be extremely unhealthy. Families are not to blame and can be the patient's providers' best allies in treatment. Sometimes families can really help them. Sometimes there's whole systems that support the maladaptive issues. Again, eating disorder diagnosis is a health crisis that disrupts personal and family functioning. It affects the entire system. When you talk about systems work, every part of the system gets impacted and affected by this. So it really kind of has that difference there as well, and some of those things that kind of come into it. They're biologically influenced illnesses, very similar to addiction, where addiction is a disease process and the way the brain kind of handles things. Eating disorders are not necessarily just choices. And this is where anorexia and some of these things really get problematic, is because we tend to think, well, just eat. If you just eat, then and it's way more difficult than that. It's not just a matter of them having desire to eat or something like that. It's they have a whole different way of viewing things with their body as well, too. Eating disorders, again, all genders, races, ethnicities, body shapes, weights, all that's affected there. Eating disorders carry an increase for suicide and medical complications. Yeah.
So, I don't know if you watched The Good Doctor, but there's an episode on The Good Doctor where they had a lady that was dealing with an eating disorder where she wouldn't eat.
Mm-hmm.
And she explained, her son was like, just eat. And she's like, she explained that she's like, every time I see the food, I hear in my brain, well, that's 20 grams of fat and 17 calories and 30 grams of sugar, and all those things keep going in her brain. She's like, I can't put that in my body, that's toxic. And it's just like this, it's more than, it's like what you said, it's more than just, well, just eat,
Yeah. Yeah, there's a lot, and that's why treatment for it is so systemic. And here's a spoiler to this, as you're kind of thinking through this, just in general, to treat eating disorders, it sometimes can be done outpatient, and sometimes it needs a higher level of care. And the general rule, I've worked with some patients, so the person in our office that handles it said, hey, can you take on somebody? She used to see me, she's stable now, but can you see her? And so I would just consult with her, okay, this is where she's at. And treating eating disorders, the general rule was, depending on their weight, so I think I had one patient that was 5'7" and 90 pounds. And the general rule was every week she had to gain 2 pounds in order to stay in treatment. And I had to have contact with her medical doctor weekly. And so if you've got to treat the medical side of this and the effect on the body as well, when people, their teeth are falling out and things like that because their body's not getting enough nutrition to even sustain itself, organ failure is happening. I mean, it's startling what the body will do when you don't give it the nutrition it needs. And so in those cases, if a week ever passes where they do not gain 2 pounds, they are removed from treatment. And there are several really good inpatient facilities across the country that are recommended in those cases. Yeah.
So in a case where they didn't gain the 2 pounds or even lost it, would they be immediately referred to inpatient?
Yes.
Okay. Because I'm done with you. You didn't gain the weight.
Whatever the agreement is. Well,
Okay.
it's not a matter of not being done with them. It's a matter of them saying this is.
I'm just saying, it's like because you just said it was like, well, you'll stop. Like,
Yeah. Then because if they are losing weight or they're not getting better, it's critical the amount of time they have in order to start gaining some nutrition.
I'm just saying that there's a plan if
Yeah.
they don't meet the criteria.
And you agree to it
Yeah.
before you start treatment. You say,
Yeah.
and they weigh in when they come in for treatment usually. You know, so they weigh in and you try to figure out, because you can't take on the responsibility of them. Because what happens, the doctor says you need to see somebody, a therapist. So they come to you, they come see you, but the doctor, and then they go, I'm seeing a therapist. So the doctor's thinking, okay, they're dealing with all this stuff. I don't need to see them that frequently. You know, and so the doctor doesn't see them. We don't communicate with the doctor. Next thing you know, things are getting worse and worse and worse. And then we're like, hey, maybe we should, you know, it's just too. So it's very fragile.
It's important to have,
You know, so if they
a
want to
plan.
stay an outpatient, then they're going to need to be making progress on it, whatever. And it's not the general. That's just a general rule. I mean, depending on where they are, they may come in with an eating disorder or something that may be a comorbidity where they have something else as well, and they're not actually going to be at a place where that great of a risk. You know, they may be an adolescent where they just started trying to, you know, do some things. But if they're bulimic and they're throwing up frequently, they can have their teeth rotting out from that, the acids from their stomach. They can have issues with their throat from the acids, and those type of things. So their mouth burns in their mouth, all kinds of different problems specific to the acids from the stomach being thrown up and different things like that. Not, or how they're causing themselves to throw up if they're sticking something down their throat, things like that. So these are all things you kind of get into a little bit. You can see how it kind of like a Venn diagram. This kind of overlaps with, you know, self-harm, sort of, but it's not like a coping for the pain of self-harm, but it's kind of like treatment of something else, but it's its own thing. So it's kind of, you really got to look at a systems look at this, because there's just so much there. But eating disorders carry increased risk for suicide and medical complications. You know, there is good treatment for it. People do receive treatment and recover. So genes and environment play a large role in developing eating disorders. Genes alone do not predict who will develop them, and full recovery is possible. Early detection, intervention are important. You know, so it's trying to get into right away. I mean, if you see people who just have an unhealthy appearance for whatever reason, and a client comes in, it's going to be a question you're asking. You know, have you ever struggled with this? A lot of times they'll say, yeah, in the past I have, and then you kind of get into what they're weighing, what they're eating now, what their day routine is, and see if they're being deceptive or if they're trying to be honest and, you know, just under stress or whatever too. So let's get into warning signs, symptoms. Common warning signs, you got weight loss, dieting, control of food is the primary concern. They try to control what they're eating, control their food. Food rituals, social withdrawal, frequent dieting, body checking, extreme mood swings. Physical, noticeable weight fluctuations, gastrointestinal complaints, dizziness standing up. Why might they be dizzy? Low blood sugar, you know, whatever. So those type of things. Difficulty concentrating, sleeping, issues with dental, skin, hair, nail health. All of those things will show signs of malnutrition. And so, you know, and so you'll see those things and kind of see what's kind of going on and realize, okay, there's some issues kind of there as well. Can be too. So they can obsess over appearance. Let's see if this works. We'll fire this video here.
Everybody, happy Thursday, and since it's Thursday here, I am answering your questions. And if any of you are new to the channel, welcome. And how you get your questions answered is I release a Monday video, usually around 10 a.m. on a Monday, sometimes noon, depends, but around that time, and I'm in Pacific time because I'm in California, and you ask your questions below that video, because within 24 hours, usually it's like Tuesday morning, I'm in the comments and I'm answering your questions, or I pick questions for my video today. Another way is to go on katiemorton.com under videos and Q&A for videos. I think it's Katie's videos, Q&A for videos, and you can ask them there. And that not only means that I'm in there answering your questions and chatting, but there's also a lot of support on the website. So if you're really looking for an answer. I know Olivia is always on there answering things. I know Sandy does a lot of work. I know a lot of people, Yar, a lot of people are on there all the time talking, answering questions. And there's probably a ton more of you that I didn't mention, but that's what makes our community so great, is that we're all helping each other, and it's amazing. And I have to be honest, I don't think there's a question I've looked at on the website where Olivia has not answered it. So thanks, Olivia. You are all over it. She has a cute little bunny. I don't know what the word is, but her little picture is like a rabbit. Okay, so this question, we're going back to our roots. If any of you remember, I specialize in eating disorders. So this question is about eating disorder, and it says, hey Katie, at what point does not eating or binging and purging become an issue? Question mark. I mean, doing it a few times doesn't mean you have an eating disorder, but how long or to what extent does it become serious? This is a question I get a lot. Pretty much the underlying question is, how sick do I have to be to say that I actually have an eating disorder? When is it really a problem? It's always a problem. I'm sorry. I know that you're wanting me to say, like, you know, not eating all for a little while is okay, or binging and purging. I don't know why my voice is like that, but you get what I'm doing. You get what I'm saying, that binging and purging is never okay for you. It's not a good thing. Not eating when your body tells you it's hungry, that's not a good thing. Now, obviously, there are going to be times when we didn't think about it and we are waiting for somebody's graduation to start. We're really hungry, but we didn't bring a snack, so we're like, shit, I have to wait until after to eat. That's not really restricting, that's like circumstantial. So let's just get that out of the way. But this is never okay. It's always a problem, because it's going to start small like that. It's going to sneak up on you like a fog, where you think it's not a big deal. I've totally got it under control. I'm just doing this because I'm getting married. I'm trying to lose weight. Or I'm just doing this before prom. Or I'm just doing this before my quinceañera. I'm just doing this for whatever reason, whatever you try to tell yourself. Eating disorders are really, really sneaky. They make me crazy like that, because it's hard to even get my clients to recognize when it's creeping back in. Because when we're recovered, sometimes we'll be like, well, I just cut back on such and such, but it's because I didn't really feel like eating it that day. Lies. Eating disorders lie. They're so manipulative. Don't believe it. If you're going against what your body's telling you, it's not good. And to reference my DSM, I might be a little lower because I usually sit my phone on all of my books, and my DSM I had to pull out because I reference it sometimes. So, and I will, if you want me to do another video about all of the diagnoses, anorexia, bulimia, and EDNOS, which isn't even that anymore, it's like otherwise specified feeding or eating disorder, give this a thumbs up. Let me know. That will tell me if you want me to remake those, because those are like really old.
We're going to go into that ourselves, into the DSM, so we'll skip on that. But a lot of good material here, and like I said, this video is up. All this is on your page. Let's look at the DSM-5 real quick. Anorexia, AN, bulimia, binge eating disorder, avoidant restrictive food intake disorder, otherwise specified feeding or eating disorder. So sometimes they don't, like she kind of alluded to, sometimes they don't meet the criteria. It's just a matter of, okay, when is it actually a problem? You're probably going to see them in this order as well, just by sheer number of what you may see. So we want to kind of get into each of them. Anorexia, let's talk about that first. Characterized primarily by self-starvation and excessive weight loss. Inadequate food intake. Disturbance in the experience of the body weight and shape. Intense fear of weight gain. This is the big part here, the intense fear. They'll have almost a fear that if they do eat, that something terrible is going to happen. It's almost an anxiety or a panic, because anxiety is so closely attached to this. Obsession with weight. Persistent behaviors to prevent weight gain. So again, and sometimes you can talk about the excessive exercise, or you may see something similar. Inability to appreciate the severity of the situation, where they just minimize and continue to minimize. It's not that bad. I'm doing pretty good. And so when you start talking with them, they will have a narrative that seems healthy. In some, I'm just cutting back, like she said, I'm just cutting back for the prom. I'm just cutting back for, I want to fit in this dress. I want to do whatever. Those type of things where you start trying to, again, it's one thing if you're saying, okay, I am slightly overweight and I'm trying to develop healthier habits to, to really kind of be healthier. That's one thing. That's a whole other thing when you're saying I need to try to change my body shape for whatever reason, all these external pressures. So you look at the trend. So you really want to look for direction of travel, not as much where they are. Does that kind of make sense? If they're at a really critical place, like 90 pounds, and I'll give you the ratios here in a minute, but if they're at a really critical place, then you're going to be more aggressive with how much you can treat somebody. And that's true of any mental illness. If somebody is like, let's say you have a client and you say to your client, hey, do you ever hear voices? And they say, sometimes I hear things. I hear somebody talk, whispering in the other room, and no one's in there. I know no one's in the room. You say, okay, so what do they say? Nothing, I just hear something. It kind of distracts us. I draw my attention to it, it goes away. Okay. That's different than command hallucinations, right? So the voice keeps telling me to jump out the window. That's a whole different thing. So you can't just go, you could say, psychosis or hallucination, but they're different. One of them might need a secure facility until they can get treatment. They may have to be hospitalized in something like Virginia Beach Psychiatric Center or Norfolk General or Maryview. And they go in there until they get the medication to the place where it's not as disruptive, and then they go out. Now, some people may get the same exact medication, but it's not critical. They can get it outpatient. And that's what you have to gauge when you start realizing there's an eating disorder. You have to immediately gauge and say, okay, where am I on this? And so now the benefit of inpatient for eating disorders is they can control everything. They control the food. They control social inputs. They control where the mirrors are. They have control over at the entire environment. And that's a good thing. The fear, of course, is when you get out, will you have the patterns and the skills to be able to continue, with the progress you're making. So that's where we want people to get to eventually. But it's a matter of whether you can see them outpatient and just start seeing them, or whether they need a higher level of care before they start seeing you. That's where you have to make a gauge. Again, if you're following this, it's very similar to addiction. Where you're constantly gauging of like, okay, do they need detox or do they need some kind of inpatient treatment for their addiction? Do they need some help coming off of opioids? Type of thing. We've had when I ran the intake department at Beach Psych, we would have people come in that would have severe, just coming up. They're like alcohol. They're drinking, way too much alcohol, and they decide they're just going to come off of alcohol. We've had tons of people have seizures. We have had holes in the walls where they fell out of chairs and had a seizure and hit the wall. Their body just reacting to the withdrawal of alcohol. So that's a whole different when you're physically withdrawing from something, So, and then there's a whole different side of that where somebody may have an addiction where it's emotionally, they don't know how to cope without it. Like if I don't have my marijuana today, I'm not gonna make it through the day. Well, they probably will, but they don't think it, right? They don't think they can. That's a different kind of addiction. So that's why you want to look at the full picture of what you're dealing with the eating disorders, because how much can they take externally? How much can they control? How's the system kind of working for them? That's what you want to kind of get into and look at. It can be really tricky too. You'll see it even in sports. Wrestlers trying to cut weight. All these type of things where they're trying to get as much body mass and muscle as they can, and then get their body as light as they can, so they can then go into and begin to they can compete more aggressively. And start to see trying to restrict water and liquids, getting nosebleeds, getting all kinds of different things. You can see people when their eyes are more sunk back in their heads, things like that, where you kind of see the blackening around the eyes, that they're just deficient of iron, deficient of certain minerals. So you can see people generally unhealthy and observe them as well. But again, a lot of them don't see how severe that situation is. So anorexia then is self-starvation and excessive weight loss. So it's that self-starvation where they don't want to eat. That's anorexia. Bulimia is the binge eating and compensating behavior. Self-induced vomiting attempts to undo the effect of the binge eating. So frequent episodes of consuming large amounts of food followed by behavior to prevent the weight gain. So they eat and then they throw it up. They really want to eat and then they're going to throw it up. And they plan or laxatives or excessive exercise. So they can binge eat and then try to have excessive exercise to try to address it too. Let's talk about excessive exercise really quickly. That's something to watch for, because sometimes excessive exercise is someone's way of coping with stress, and it can be a healthier way to cope with stress. You know, I've had patients that would lift weights, then would get on a bike, ride a bike for an hour, and then they'd go swim 2 miles in a pool, at the pool, because they didn't want to go home that night. They just getting off work and going home to the empty house where their significant other wasn't there anymore. You know, they wanted to go, they would get that high of that adrenaline of just exercise, then they would go home and rest and sleep. So they would use health and exercise to cope emotionally. That's different than trying to get rid of weight gain from binging or eating. That's a different thing. So again, you want to look for balance in everything. Where's the balance? Do they have balance? What's excessive? You know, those type of things. The feeling of being out of control during binge eating episodes. Sometimes they'll eat and they'll feel like they're out of control, and they'll have extreme concern with their body weight and shape. And most of them are normal weight. So you'll find this pretty popular among the adolescent population and those type of things. And again, the earlier we catch it, the easier it is to treat. But it's characterized by recurrent binge eating without regular use of compensating measures to counter the binge eating. So binge eating disorder instead of bulimia. So binge eating is recurrent binge eating, and they're not trying to compensate. So they're eating when they're not hungry, eating to the point of discomfort, eating alone because of the shame of the behavior. They're getting up at night, they're eating the whole cake. They're like, I want the cake because I'll feel better. Eventually the sugar will kick in and I'll feel better. That's binge eating. But again, a lot of strong shame and guilt once they're done. Again, you see a lot of these same trends with a lot of different things that people do to treat emotionally when they kind of are done treating it, just the guilt of like, why am I doing this? So, you know, or just even the obsession with, you know, I need to find this, or I need to get, you know, this new exercise thing. You ever look at when exercise machine equipment things are on TV commercials around what TV shows and different things like that? It always blows my mind what, you know, during the day what commercials run considered to during, you know, evenings. I mean, everything's really meant to target, you know, specific people and what shows they're watching as well. But again, you're looking for this. In this case, binge eating disorder is just that, eating to change the way you feel. You know, when people are eating to change how they feel emotionally, they're going to eat all different places, eat whatever they want to eat, as much as they want to eat, to the point of physical discomfort and even hurting themselves. Avoidant restrictive food intake disorder is a lack of interest in food, fears of negative consequences of eating, or selective or picky eating. Now, okay, so just to clarify, we're not talking about somebody who is trying to eat healthy, to eat organic, or not eat certain types of foods, you know, for some reason, you know, for like, you know, they're vegetarian or something like that. That's not a disorder. You know, but again, you're talking about that selective, picky eating, reduced food intake, frequently complains of body discomfort with no apparent reason, lack of appetite or interest in food, or the range of preferred food that narrows over time. So over time, they'll only eat certain foods, and they'll only eat like a rabbit of certain foods. That's restrictive food intake disorder, you know, where they begin to struggle with restricting food intake. And so other specified eating disorders. Again, we have atypical anorexia. So it's criteria for anorexia, but the weight is not below normal. So let's say they're doing their restrictive eating and they have the anorexia type of thing, but their weight is within normal limits. This is something you're likely to be able to treat in outpatient, right? Because their body weight is not at a level where they are necessarily in danger of their life. Now, with any of these disorders, you're gonna have medical treatment. It's the best practice to make sure people are seeing a physician every time they see you. So the question on intake is, when's the last time you saw your medical doctor? When did you have a checkup? You know, what did you tell them? What do they know about this situation? You know, do they know you're feeling depressed? Do they know? So, because they're going to look at it from a different side that you're not skilled and trained to do. They're going to be able to run lab work and look at different things in their blood. They're going to be able to look at factors of health and history, and they'll have a baseline for them and look at the trends and the changes. So those are the angles you're kind of looking at. You're seeing a whole different side of things, if that makes sense, right? And so atypical anorexia. Then your sub-threshold bulimia is criteria for bulimia with less frequent occurrences. So they may have it happen once or twice a month, or they may have it happen, it happened 2 weeks ago, and then it was a month before it happened again. So they have it happening, and they slip into this rut. Now, what are you going to look for if you see that? You're going to look for what triggered it, what changed. Break up with a boyfriend. Okay, now they have a breakup, they feel unattractive, what happened there? Time of year, summer starting, all these different pressures. So you're going to look for some of the trends around what's building their mind around these things. But that's sub-threshold bulimia. Sub-threshold binge eating criteria, but lower frequency. Purge disorder, purging without binge eating. So there is a purge disorder. People who may not binge, but they still want to make themselves throw up. Night eating syndrome, excessive nighttime food consumption. That's an awesome one. You get up and you're like, I got to eat. Like, I just want to eat right now. You'll find kids, it's really funny with kids, I have 4 of them, and you'll find with kids sometimes that when they get tired, they want to eat. So they can't differentiate the two. Another thing people struggle with is 30% of the time we're hungry, we're actually thirsty. So we're not hungry at all. We're thirsty, we want water. So it's really bizarre how when we don't get enough water, how that affects our bodies and our minds and everything else. So, but again, a lot of times kids, they start to feel what the antidepressants kind of kicking in. They have that, I'm sleepy, and they're like, I don't want to go to sleep, I need food. Because they already know, if I eat right now at 9 o'clock right now, I'll feel a little more awake. The blood sugar rises. So they're eating to change, they're not eating because they need nutrition, they're eating so they can change their energy level. And that kind of, and we do that now. Like some of you ate before you came in here, and it was still pretty late to eat. And some of you didn't, and you're tired. You're thinking, I should have packed something. I didn't bring this. I should have brought whatever. You'll find all those types of things kind of kicking in to try to affect that too. Doesn't mean you have a disorder. It means it's not uncommon at the lower levels. So if you're looking at these, you're seeing these are serious, but they're people doing things to try to adjust their bodies in ways that are not healthy ways of doing them. And you'll see that the primary other diagnoses of these are more severe, is the big difference there. So co-occurring disorders, again, high prevalence rates. We talked about that already. You can intensify eating disorder symptoms and impact treatment as well. Most common comorbidities, mood disorders, anxiety, and substance abuse. So why the comorbidity there? Why mood disorders? What do you think? Yeah.
Because your food affects your dopamine levels and your mood. I know that the term hangry, when you're hungry. I know I am. I get angry.
I've never been that.
No.
But don't ask my wife.
I get angry when I'm hungry. So
Yeah.
That's like mood disorders.
Yeah. So your mood disorders, it does. Eating can manually affect. So why substance abuse? Because it's the same thing. I mean, if you choose food to change your mood, or you change a pill to change your mood, it's the same thing. Like, so you're either way, you're manually, externally changing something in your mood. Anxiety is the same thing. People do a lot of things that to cope with anxiety. Again, their brain starts triggering, they have certain feelings, so they try to cope with those feelings through food. We've all heard of emotional eating, things like that, very similar. Yeah.
I just want to make a comment. I think I was reading something about how they're finding that sugar will light up like certain same areas of the brain as cocaine will.
Mm-hmm.
So that's why you find a lot of like sugars and foods. And also, when I used to be a smoker, I found out that years ago that they used to put sugar in cigarettes as well.
Mm.
just to make them more
Yeah,
addictive.
sugar is a very powerful chemical, and even the substitutes for sugar are really affect the body in certain ways and make you feel depleted and different things like that too. There are a lot of medicines that have that effect to them as well. Like there are certain antacids you can take, like Tums I think is a good one. But one of the other ones you can take, it actually has a drug in it that at the end of taking the drug, when the drug's wearing off, when like the whatever substance starts wearing off, it does the opposite. It'll increase acid to take, then you'll need another one. It actually works that way. So it actually does it makes you feel better, you get relief, and then you need more. And so now I believe it is, my wife's an expert on all this stuff. Tums I think is the one that when you take it, it will actually not, it won't do that. You take Tums and it'll immediately, it doesn't trigger that part of the stomach to create acid again.
I think it's pretty much just sodium bicarbonate with flavoring.
Yeah.
Very simple.
Yeah. It's crazy. So a lot of stuff with food and stuff has a lot of these effects to it as well. So that's why you're going to find people who externally want to change the way they are feeling will use all kinds of different substances. I mean, it just depends on what I told you before how many people refuse to take medication. They're like, I won't take a pill for anxiety, but I smoke marijuana. You know, I won't do this, but I drink alcohol. You know, so people learn to self-medicate, and people self-medicate with food. Food's socially acceptable. It's one of the more socially acceptable treatments in the church, right? I mean, you know, so you're not just like an alcoholic, you know, or something, or you're not taking drugs, those drugs that people are doing, you know, but you will way overeat so you feel good, you know. So, you know, it's more acceptable in certain ways, but again, it's the same thing where it should be a red flag to say, okay, why am I trying to choose this to change the way? Now, there are certain levels of things you can do to change. You know, exercise may change the way you feel too. It releases endorphins. You know, so at what point is exercise not healthy? You know, and so where are you? So you have to look for whatever's healthiest to kind of manage these things. So it's not really a shame thing as well. Yeah.
I'm not sure if it was mentioned yet, but as the eating disorders are being treated, do mood disorders, anxiety disorders, and substance abuse tend to go up?
Well, okay, I'm glad you brought that up. So let's say you have a client, and it's a husband and wife. Husband's concerned about wife's alcohol consumption, and so husband says something in therapy, and therapist says, why don't we go ahead and discuss, to the wife says, why don't we discuss the role of alcohol in your life right now? And she said, I'm done with this. It's ridiculous what we're talking, and she just has all this pushback. So if there was an alcohol relationship in that person's life that was within normal limits, you would say, yeah, let's talk about it. You know, I mean, if it's really bothering you that I have a glass of wine at night, then I don't need the glass of wine. You know, I mean, that's a healthy relationship with alcohol. Sort of, you know what I'm saying? But the fact that if somebody's using like a crutch, we'll just use that as an analogy. They're leaning on this crutch of the alcohol to make it through the night, and the husband says that crutch has got to go. They're not gonna go, oh sure, because there's nothing else. They don't have anything else. And so what you find is that when somebody has something in their life that's a coping strategy, and you touch it, you're gonna get a reaction, a strong, and it won't be a normal reaction. It's gonna be an abnormally strong reaction. And that's your indication that this is a coping strategy. To go to your question though, what your point is, exactly that. You need to develop, while you're addressing the eating disorder or whatever the addiction or whatever it may be, you're gonna begin saying, okay, let's develop new coping strategies. We need to have things in place for you before we take away what you're using. You can't just take away what someone's using and have them have nothing. They won't let go of it because emotionally they don't think they can make it without it. So once you start connecting them with other tools, then they feel like they can let go of it. They won't drink as often. You know, they kind of move away from that. I had a patient who's trying to get pregnant, would drink a bottle of wine a night, having trouble getting pregnant. If you look at the research, I did a lot of research on it at that point. If you drink 5 drinks per month or more, you have like 40% less chance of healthy pregnancy. So alcohol is like pouring water on top of a fire and trying to start the fire when you're trying to get pregnant. So for her, it was like, okay, look, so the more she struggled with pregnancy, what more she did what?
Drink.
She drank, yeah. So it was like she's got this cycle going, and then she's like, well, maybe I need to go to in vitro fertilization. So she sees fertility doctors, gets more nervous with the procedures, and drinks more. Well, there is no sense paying $30,000 for fertility services when you are pouring water on the chance of doing that and sabotaging it with alcohol and not even thinking. So at that point, you start thinking, okay, you have the conversation, a very blunt conversation, say, look, you're going to need to back off of this, and when you do get pregnant, you're not going to be able to drink alcohol. So, what if you got pregnant right now and you had to just quit alcohol? So let's back the alcohol down and let's start finding new things that you can cope with, that you can use when you are pregnant, and that'll also help your chances of getting pregnant. So you can kind of start to maneuver that. So yeah, you have to address the whole system and the reason that they're doing these things. So you're going to be addressing self-esteem. You're going to be addressing social triggers for the way people look and all these different things. You're going to start modeling those things, processing those things. You'll find a lot of adolescent girls will do posters and different things. I have therapists that work with kids, and they'll cut out things that they think are attractive and why, or what are things that are described inner beauty of whatever. And they, again, just pulling magazines and cutting things as activities in therapy, just to start to develop a new framework of what is beauty and what is, these. So all of those things can help systemically address. So when they do back away from the eating disorder and their body begins to become normal again, they can view that normal as healthy and beautiful. Does that make sense? You don't want to just take away everything and go, good luck, So yeah, you have to address all of it. That's why you need a really good picture. I use the phrase often of unpeeling the onion. I always say, let's make sure you unpeel the onion. Unpeeling the onion means you think you see the eating disorder, but they come in, their legs are this big around, okay, you're like, whoa, that's not healthy, something's going on here. You begin to start unpacking that a little bit, but you're also looking at their emotions, their anxiety levels. You're assessing all of that to get a picture of what's going on beneath the surface. It's easy to look at the low-hanging fruit, right? That's low-hanging, easy fruit. But look deeper than that, because everybody can do that. Look at what's deeper, and then once you get a better picture of that, you're going to start assessing for strengths. What do they have that they can build upon? What can you build upon that can help them develop coping and address some of these needs? Are you the right level of care, or do they need a higher level of care? Do they need inpatient? Or some kind of thing, So nobody wants to do that. A lot of times, I had a patient, she was a mom of the baby, and she was like, she couldn't just go to inpatient. It wasn't like, and so at the same point, you're not going to be here for your baby if you continue this. So it's a matter of what can you do. Ends up her parents ended up stepping up. She went to some place for a month or 2 months or 3 months, and got some treatment, came back, started doing pretty good. So but again, to get that person to swallow that pill of like, hey, this is what you need, can be complicated. You have to build a lot of rapport and trust. So, but yeah, good points. But treatment's got to address the coexisting conditions of the eating disorder. What the whole thing, what's all going on. There's no sense in trying to adjust binge eating or something like that, or some kind of eating disorder where they're eating just constantly, just threshold binge eating, or something like that. When you're not dealing with some of the emotional factors that may be triggering that as well. Heart health you got cardiovascular, muscle loss, low irregular heartbeats. Some of this can be permanent, by the way, and they can recover and still not get the muscle back in the heart and other things. Gastrointestinal issues, very common. Neurological issues, difficulty concentrating, sleep apnea. Endocrine, hormone changes, estrogen, testosterone, thyroid, those can be also permanent as well. So they can begin to change, and they can be permanently changing the structure of their body and their body ability to function normally. In a lot of cases, they can get back to a normal levels of what they're doing, but again, you're talking about they're losing chunks of hair, and they're losing. Their body is just physically showing that they don't have, it doesn't have the nutrition to continue supporting life in that body. So it's slowly watching somebody die, like almost like cancer, only it's from a behavioral thing of eating. It's very difficult. Yes.
I thought sleep apnea was to do with breathing. How does this eating disorder result in sleep apnea?
Well, it can affect, so let's say you're overeating, it can put a lot of pressure up into the areas of sinuses and things like that. So one of the, being overweight at all is one of the indicators of sleep apnea. So it can have to do with that too. Remember, not all of these are from restrictive eating. Sometimes it's overeating. But difficulty concentrating, things like that too. There still is a lot of research going on about sugar in the brain and its role. There's some indication there's a strong connection between Alzheimer's and sugar. So they're looking at the comparisons between that as well. So again, some of these things are really, really dangerous, even though they're very common, and they're things that are embedded in our foods and things like that too. So 50 years of research confirms that anorexia has the highest mortality rate of any psychiatric disorder. So people die from anorexia more than any other mental disorder. Risk of death from suicide, medical complications is markedly increased for people with eating disorders. So you're going to check for suicide thoughts, plans, whatever, if you're dealing with people with eating disorders. Please keep in mind, when people come into your office, they're going to minimize their symptoms. Almost all of them. The only example that would be different is if they're coming in intentionally trying to beef up their symptoms. So it's really trying to kind of, like if you look at the Beck, you guys familiar with the Beck Depressive Inventory? If you give somebody the BDI, if you look at the scoring on the BDI, if they score too high on that, it's not a sign of depression anymore, it's a sign of a personality disorder. So if they come in really like, life is horrible, yes, loss of interest in this, yes, and they're all 2, like they're all like super high, you're looking at a personality disorder, not necessarily depression. So just understand that dynamic, because you can kind of find some different things that kind of roll together in these things as well. But again, you're looking at a lot of different things kind of flying in there. So keep in mind, they're going to minimize. They're not going to come in there. They're going to come in saying, I'm doing pretty good, but some things. They're going to come in for marriage counseling, couples work, and they're going to go, we're doing really good, but we just want to get things a little bit better. We just want to tune some things up. They come in with this little, and you're like, oh, cool, tune up. Then you find out, one of them's dropped the D word 3 days ago, and that's where the tune-up's coming from. It's like, she asked for a divorce 3 days on Sunday. I called you Monday to get you in on Wednesday for the tune-up. So, that's kind of, so if you go into a session when someone comes in, whether you're in practicum, internship, outpatient, whatever you do, you need to have the mindset that before someone would walk into a strange room with a strange person and try to open up about something, they are profoundly distressed. That's not the first choice. They're not like, I'm going to go talk to a stranger and hope they can help me. They are really in a bad place. So understand they're probably at a lot worse place. It took a lot of courage to even get through the door. If you come in at that level, you're going to appreciate whatever they tell you. And then when they try to paint a picture, they don't want the social, like you take somebody with an eating disorder, they don't want the social rejection from you, of like, ooh, your body looks, weird. They're like already like wigged out about that. So they don't want that. So what you'll find too is there's a high success rate of people who get social disorders, and some anxiety disorders, and eating disorders via video, telehealth. So because, if they have some kind of body dysmorphia, they don't like their body, and they come in, there's that risk of that personal interaction of seeing people who notice them looking different or whatever. So a lot of times people actually will prefer or try to have counseling by video. So a study on BN found that elevated mortality risks similar to those for AN. So, so if there's purging and things like that too, again, you're looking at mortality rates skyrocketing too. Seeking treatment, they're not phases or fads. Highest mortality rate, we talked about serious effect on the health and relationships. Early intervention is the big key here. Intervention, you want intervention to go into professional treatment, ongoing support to recovery. That's kind of a trend of what you want to do. You want to have some kind of intervention to say, okay, let's make some changes, continue treatment, they continue support, and they continue to get better. This is not just like you're going to throw an intervention at them, they're going to totally turn this around. They need to slowly build back their health. And it often cycles. People will have a problem with anorexia, and then it's better for years, sometimes 3 years, 4 years, and then they have another bout of it again. And so they may come back in the second time around to see you, and they're panicking. They're like, I'm not eating, I'm restricting my eating, I'm doing this. I had a problem before, it was better. It wasn't until my husband and I started having problems, and now whatever. And so whatever may trigger it, suddenly they come back and they're scared. They see what's going on. They've been there before. They've made some progress. They've been in recovery, and now they're feeling like they need help again. So, so you're going to do the initial assessment, and then figure that out. There may be different providers. Communicate with everybody involved. Develop, maintain a plan. You want to interview providers. This is critical for this. It is absolutely critical that you find out who their physician is and you meet with them. In fact, I would recommend that they need to be seen by a physician. They may come in and say, I have a doctor, I don't want to give you their information. What does that mean to you, though? Their doctor has told them, they need inpatient, they need something else, and they're not listening to their doctor. They don't want you to talk to their doctor. So you may set criteria and say, I'm not going to provide care unless I speak with your physician. And so, because you're not taking your liability and someone dies under your care, because they don't want you to talk to the doctor. And the hard part is you're going to see them come in your office and they're going to be like, you're going to panic. You're going to be like, they don't look healthy. They need help. I need to help them. I need help. Guess what we do? We help people, right? Mm-hmm. And then, for you to set a boundary and say, I will not help you if this criteria occurs. You have to have some boundary of saying, we'll continue working as long as this is something healthy and as long as you maintain direction of travel that is safer for your health and you're under the care of a physician. And you're going to want to talk to that physician and say, are you under the care? What do you notice for change? This is what we're dealing with. And you're going to collaborate because there's strength in collaboration, especially in areas that you don't know, like her biology and her lab work and all those things, or his, whatever it is. And then what are you going to do? You're going to document it. If you didn't write it down, it did not happen. If you don't write notes on it, it didn't happen. And so the providers I know that work with eating disorders have significant, massive notes that they're writing on their patients. The notes are not like 4 sentences, 5 sentences. It is like a lengthy outline of everything that's going on. Then they're talking to physicians, noting it in the chart. Called this doctor, spoke to them about this. Because this is a very deadly disease, and if something happens and family wants to sue you, you need to make sure your documentation is in place, that you've done good due diligence, that you've done a good job with this too. And remember, if you don't have a specialty, if this is not an area of strength for you, if this is not something that you do as your thing, you are going to want to get supervision and collaborate with people and make sure you're working closely under somebody who specializes in this so you can gain that skill. And that's how you gain the skill. So you're going to do the assessment, diagnose, then you want all providers. Who are they talking to? Do they have a nutritionist? You want to talk to the nutritionist. Primary care. When's the last time you saw your primary care? You need an appointment by this date so we can continue care. I'll see you next week, but if you don't have an appointment set with your primary care by then, we won't be meeting after that. And then if you don't see that primary care within 2 more weeks, we will not continue care. It is critical that you receive this. So you have to kind of make sure that you're getting the information you need and they're getting the care you need. Communicate with everybody involved and develop that plan of what they need to do. So inpatient, residential, partial, intensive outpatient, outpatient. This is the level of care, the care continuum. And so you have to realize this is you, more than likely, okay? So you have to, unless you work in one of these, But if you're doing outpatient, you see them, or you're an internship site, you see them, you have to look and say, okay, where are we on their continuum of care? You don't want to be the rescuer here when they need something far greater than what you're offering. You know, you have to make the evaluation at intake of whether you're a good match for somebody or not. I had a patient once. I immediately referred. I said, I can see you, but the specialty you need is not me. You know, I mean, here's what I can do for you. I can help you handle your anxiety, this, that, and I kind of left some things. I had a patient once that said, they said they had an encounter with a very, very special encounter with the white buffalo. And the white buffalo is one of the highest levels of spiritual awakening for Native Americans. It's like if you're a Native American, you saw the white buffalo, you were like chosen to see the white buffalo, and it is a high level of. So there was a level of spiritual connection and spirituality that was very prided, you know, and a lot kind of going on. So it's really complicated to figure out what is psychosis and what is a story she's making up, or what did she actually see, or did she have some kind of encounter, or what? But I happen to have a really good friend that worked in alternative treatments for counseling and different things like that, and they worked with, you know, everything from Edward Casey type of New Age type of treatments to natural, holistic type of, but they were very good in alternative treatments. And so I basically said, hey, I can help with some of this, but I know somebody who's really good at what you probably would benefit from, instead of telling me any more of your story and we keep spending weeks talking about this. And I sent that patient, I said, if for some reason you can't get in, come back in and see me. But I really think they met once and they both were like, this is amazing. And they've seen each other for years and done really well. So it's like, that particular was a really strong match. And it wasn't like I was not going to see them because I wasn't comfortable with the content, or I was like, well, I'm not into your spirituality. It wasn't an issue like that at all. It was a matter of, hey, there's somebody really good at what you're trying to do it. And you're going to run into that with eating disorders, because you may say, I can handle this one with some supervision and know the person you want to supervise you. Or you may say, this person looks like they're going to die, and I'm not good at that level. Like, I've only seen this once or twice. And then you're going to say, look, you know, I can't help you. You're going to need a different level of care than what I can provide. And then you're going to document that. So, but that's the reality of what you're going to see, because you can't handle everything, but you can't discriminate. Like, you know what I'm saying? Do you understand the kind of a difference there? You kind of need to look at what your strength is going to be. So again, outpatient, intensive outpatient, partial hospitalization. Partial is usually a step down from inpatient. Very rarely does somebody go into partial. It's normally, remember we talked about ongoing support and recovery? This is what partial does. This is inpatient, this is partial, this is outpatient, generally. Does that kind of make sense? So partial is a step down. So in other words, they'll go to inpatient for a month, or 2 weeks, or whatever, or 3 months, 6 months. And then they step down, they come to a partial, where every day between 8 and 5 they go to partial. Or they go Tuesdays and Thursdays for 8 to 5. It's a daytime support system that kind of is a partial, and then they wean themselves off of that to outpatient, and that's how they maintain. So that's how that kind of generally works, going downward that way. So yeah, there's a lot of different resources and things too, just to kind of give you some idea on that as well. But well, that's on the Blackboard shell, so if you need that, hopefully that's helpful. Any questions on that? While we're okay, cool.
I have a question and a comment.
Yeah.
When we first started the slide, and it said that 20 million women and 10 million men.
Mm-hmm.
And I have to admit that I was surprised at the 10 million men. 20 million women, I miss a lot, but I'm not surprised.
Mm-hmm.
So what,
Yeah.
on the 10 million men, is it one type of eating disorder mostly for men, or is it just kind of one, just like women?
No, it can be the overeating, it can be the purging, it can be any of that. I think bulimia is primarily, maybe 2 to 1 more women purge. Not really sure exactly on the numbers on that. I do know, and it's not limited to this, but I do know in the gay communities, eating disorders are significant. They're significantly high. So is domestic abuse. So is, a lot of that is kind of high. Substance use is 60%, maybe more. I mean, it's significant too. So, different populations you'll find that tend to have different kinds of ways of coping with things. Like kids and adolescents may have certain ways of dealing with, eating disorders that are more acceptable for their way of, doing that too. But it can vary on how that kind of looks and how that works. Yeah, I agree. I think the problem with that is I like that you pointed that out because, I think it's hard to recognize. We wouldn't look at that for a male, in various forms. We may look at it if they're struggling with their health from overeating, but I mean if they're extremely trim and lean, we may think, oh, they're just really fit, and not think,
Or if they're working out all the time.
yeah,
Yeah.
exactly. So just kind of, examining the healthy, you may say weight gain. I always inquire weight gain, weight loss. I want to know what people are going up and down. What's extreme up, extreme down are all red flags. And it can be stress. I know people that their body just shuts down with stress and they just don't want to eat. They're just like, I can't eat. Haven't eaten a good meal in weeks. And just so all of that again is signs of, getting them to do different things or drinking meal replacements or whatever if they can't eat. There's all kinds of things you kind of recommend. But generally, before you start doing meal stuff and trying to give that recommendation, you can give some general recommendations. You should immediately be thinking medical people need to be involved in this. Nutritionists. If you start dealing with this population, you'll know nutritionists that are really good. You'll know which doctors are primary care. So they may say, I don't have a primary care. I want you to call this doctor, see if you can get him in, tell him I told you to call. That doctor will know. That kind of thing. Like I have a therapist friend that specifically confronts strong women with mood regulation issues. So when I see a couple, I'll say, it would be good for you, male, to go see so-and-so or whatever, and you, female, to go see so-and-so, and I send them specifically to and that therapist knows. And that therapist sends me angry men. So I know when it's like, I talked to Miss So-and-so, Dr. So-and-so said to come, I know, okay, got an angry guy. Yeah, we already know. We had the conversations of like, and so we kind of know what the strengths are, what we need in that. And so I have a staff, like it's like I'm staffing it. Like I hired somebody who's really good at marketing to do my marketing. It's not, but I know who's really good in certain areas that I can kind of get to, look at things. Sometimes people will say, I really need this kind of person, somebody can really nurture and reach my son. He's really having a hard, and I'm like, yeah, your son doesn't really need nurturing that much. You need somebody they'll connect with, and I'll send her to this. We have a couple good therapists in our office who will say this person will be really direct with mom. Like I know child counselors. I have a counselor on my staff who won't counsel a child without the parent present. And it's not that they don't want to counsel the child individually. It's that the parent needs to learn how to. She'll model things the parent needs to go do weekly and regularly. So she comes fully from a systemic view of child therapy. And so it's very specific, but it can be, I know if I see a system that's kind of broke and the parent's like, the child just needs therapy, I know that's the place to send them because mom will also get the therapy or dad will get the therapy they need to deal with the child. Because I know that therapist deals with it that way. So that's what you'll learn when you start developing community-wise, which is why we talk about professionalism and function and way you starting at your internship, you will immediately be known. You can start getting known around here in the community as the way you do things, so you want to maintain that level of professionalism starting now because you're going to start developing that level of connection. All right, so we covered the DSM pretty well. in that PowerPoint, and that's why I like that one. Let's look at the sleep-wake disorders a little bit too, because we're covering those as well. So we have insomnia disorder starting off. Predominant complaint or dissatisfaction with sleep quality associated with one or more of the following symptoms: difficulty initiating sleep. So in children, they might need their parents to help them get to sleep. Difficulty maintaining sleep, frequently waking up, early morning wakes with the inability to return to sleep. And so sleep disturbances causes clinically significant distress. This is the key right here. Clinically significant distress and impairment. And again, you're looking at this, and this is a common trend in the DSM, okay, is clinical significance. 'Cause that's a big difference between I don't sleep good either type of thing, you know, and clinically significant distress in multiple domains. So this is what you're looking for, again, for criteria. In impairment in social settings, occupation, trouble at work, education, can't stay awake in school, academic, behavioral, and other areas of function. Okay, so this is critical because when you're looking at ADHD, or you're looking at other kind of oppositional disorders, various things, it's looking for multiple domains. It's not looking for just one domain. If somebody's got an issue with one domain, that's a little bit different. So let's say they come to school and they have no problem whatsoever, you know, functioning. And then they go home at the end of school day, you work in the school, at the end of school day, the child, 3 o'clock rolls around, they start acting out, freaking out, acting weird. So they don't like to transition back home. You know, that kind of thing is a bit more of an issue. You want to look at what's going on in the home domain and what's going on there. They may not meet criteria for the oppositional, but again, in this kind of thing, that's what you're looking for. You're going to see that clinical significance in multiple domains is a trend among most diagnoses. Sleep difficulty 3 nights per week or more, present for at least 3 months. And sleep difficulty occurs despite adequate opportunity for sleep. So it's not like they're working midnights and they can't sleep or different things like that. It can be really tough. I remember when I worked in law enforcement, we worked 12-hour shifts, and we would work nights, and we worked from 6 p.m. to 6 a.m. That wasn't the problem. The problem was that court time was all set around attorneys. So if somebody's an attorney and they're like, I got court in this city later, so I'll do this on this day, they would just move your court dates around. So you just get a subpoena, like this is when you got to appear in court for the arrests that were made or whatever happened. And so I can remember times when I would work 6 p.m., I'd be up all day with my kids, go to work at 6 p.m., stay up all day, all night. About 6 in the morning, you get really tired. 6 in the morning, try to get some sleep for a couple hours, so I had court at 9. So I sleep for like an hour, I'm up, I have to drive to the courthouse. I have court at 9, and I have a docket call at 2 for more court. So I have court at 9, grab lunch, court at 2. I'm done, I sit and wait for my case to be heard till 3 or 4. I gotta be back on shift again at 6. And then I have to work another 6 p.m. to 6 a.m. And then that doesn't tell what you may have the next day. So you can be up for a solid 24 to 48 hours and have no sleep. And then the nature of what you do for that work, where you have to make decisions, like in that critical moment under stress, in the middle of the night, driving or responding or life or death. I mean, that's the nature of the job itself. So that's where the complication gets in. That's not what we're talking about here. We're talking about when you have opportunity for sleep. So if somebody's in military or they're in certain things or it's some kind of a cycle of work where they can't, that's a little different. So insomnia is not better explained by other things: sleep-wake disorder, narcolepsy, breathing-related disorders, rhythm sleep-wake disorder. Saw one of those recently in a patient. Patient had a history of if I get off and I just stay up till 2, then I can't sleep again, and the body, and this particular client's body switches. And so when the sun comes up, gets sleepy, tired, like a fall over sleep, and then when the sun goes down, wakes up. And the whole cycle, it's not just a matter of I can't sleep at night, it is the whole cycle of their body gets off. And the only way they can correct it is to stay up the full 24 hours and go to bed the next night, and they can immediately switch it back. And so, but again, you're looking at some of those type of things may have some problems too. Again, you might be also dealing with bipolar disorder, with mania, and other things like that, where people are staying up for long periods of time too. So, substances, drugs, medications, watch out for those. Coexisting medical conditions as well. But again, you're going to kind of find those different things and specifiers. So insomnia disorder can be just that level of they really can't get to sleep. A lot of times they may try different medication. A lot of times they may try alcohol. Alcohol makes people tired, but terrible sleep. It just does not provide good rest. People wake up and they don't feel rested. People will take melatonin. That's a famous one. It's found in meat. You find it in any drugstore. It's like I would encourage you, by the way, if you ever have the inkling to do so, look up melatonin, all the medical uses for melatonin on us. Just search for it, Google it, and you'll find under different doses, melatonin's used to treat a lot of different things. And so it's just interesting. I wouldn't go off those searches and go, yeah, I'm going to prescribe it type of thing. You can't do something like that. But your trazodones are much better sleep agents. They're not a habit forming. A lot of people will take trazodone and helps. Risperdal, you'll find kids are prescribed Risperdal to help sleep. Sometimes antipsychotics, all kinds of different things. So doctors will judge at how much they need to help them sleep. And some people fight sleep so hard in their mind that they really have a hard time. But so it's important to know whether they're having trouble falling asleep or they're having trouble staying asleep. Because a lot of times racing thoughts and anxiety will keep people from sleeping. They feel vulnerable. Their mind feels like it's not hypervigilant when they're sleeping. First opportunity to wake up, they're like, this, that, take care of this, take care of that. If you're worried about this stuff, it won't have to be bad, and they have some trouble with that too. So just watch for that too. You can see the difference on that too, though. And again, you got the symptoms at least 1 month, less than 3 months. You have these different episodic, persistent, recurrent classifiers. Just look through some of your classifiers on that too. How you specify it with any kind of comorbidities or whatever else. One of the big things here, it says dissatisfaction with sleep quality or complaints maintaining. That's the big thing they're going to come in with, is just a matter of, not really getting the rest that they need. Tons of people have this issue, by the way. It's just, it's pretty common. And so you can kind of read through some of this as well. Differentials here, you've got normal sleep variations, delayed sleep phases, restless leg syndrome, breathing related, sleep apnea may have the same things. So people who really have significant struggle with this, you may want to have them talk to their primary care and see if the primary care wants to send them for a sleep study. A lot of times sleep studies reveal a lot of things going on in people's sleep that can be really helpful. Sometimes apnea, sometimes it's not apnea, but those type of things as well too. So, okay, hypersomnolence disorder, excessive sleepiness despite sleeping at least 7 hours. Again, constantly. Again, no drugs, no substances. They just kind of can't wake up. They're constantly sleepy. Usually, again, accompanied by significant distress, impairment in these areas as well. So again, just be aware of it. Very rare, I think, to see that as often. Again, look at your differentials as well. Narcolepsy, recurrent periods of sleep lapsing into sleep, napping, recurring same times, occurs 3 times per week over the last 3 months. So again, you're looking for your qualifiers there. So episodes of cataplexy were defined by either occurring a few times per month, long-standing disease, narcolepsy. Again, people just fall asleep. They just stand there and they'll just fall asleep. You'll see it. I've seen 2 or 3, maybe, people with narcolepsy. And so I'm not gonna lie. I've been sitting there going, "Please don't fall asleep in here." I don't know what I would do. I have somebody right behind you. I'm gonna wake you up. Can't be like, I'm sorry, I can't have a room right now. They're sleeping. So, but so you can kind of see some of those values as well. again, you're gonna definitely get this into a medical professional if you see some kind of narcolepsy or complaints of it. Breathing related sleep disorders, obstructive sleep apnea. Again, that's not something you're gonna diagnose, but be aware that it's there. It's in the DSM. Central sleep apnea, again, doesn't really come up with, they're just not getting any other kind of breathing. Not, they're just waking themselves up with their breathing, different things like that as well. And comorbidities, sleep-related hyperventilation. Again, this is something a doctor will diagnose with more than you. You're just gonna know they have a sleep disorder in general. Just be familiar it's in here. And we talked about circadian rhythm sleep disorder already, wake disorder. You know, again, you're gonna look at those type of things as well. One thing that's not in here is seasonal affective disorder. We'll get into with mood disorders, but it's kind of similar, where people tend to they'll cycle. So I have a client that I saw for years. I don't see him anymore, but I had a client I saw for years. And the first time, it was like July 11th or something like that. Second week of July or something, roughly around there. I met with him. I saw him in his house. I worked in the community with him. And he just had this, he started talking kind of crazy. The police are coming. Anyways, he ended up getting hospitalized. And when I took him to the hospital, well, they took him to the hospital, but when he was screened and stuff, and they knew him by name, and they're like, "Oh, he's back." They looked at me and they said, "He comes in this week every year." And I was like, "What?" Like every single year, the same week, they know he's coming in. Like he's done it for like the last 8-9 years. And so, no idea why he has psychotic episodes during the same week of every year while taking his medication. Didn't stop his medication. Or he may have stopped it that week or something like that. But for some reason, that 1 week, they said he always comes in that week. So you're going to find some people have struggles with different seasons, those type of things. But again, you're going to find that when they get off during their sleeping days, awake nights, and they can't figure that out, you're going to figure out why that is too. Delayed phases. Environmental factors, there's a bunch of different factors there too. Grad school, that was in there. Just kidding. Yeah, it's the truth. Non-24-hour sleep-wake type. Some people, they have extremes on that as well. You'll find this sleep maintenance and sleep hygiene are terms in that. What is their sleep hygiene? How are they preparing to go to sleep? Are they drinking energy drinks really late at night? What is it that they don't want to sleep type of thing, or are they struggling with that? Those are all things you can explore with them. Parasomnias, abnormal behavior, physical events associated with sleep. Rapid eye movement, sleep arousal. So non-rapid eye movement, where sleepwalking, sleep terrors. So you're going to find people have those pretty common, where they start to have that sleep arousal disorder. Where they will get up, walk around, or they'll have terrors in the middle of the night. Usually begin with a panicky scream, intense fear of autonomic arousal, sweating, those type of things. They may not remember, they have very little recall that even happened. And so if you ever have a spouse that has that, you'll know about that right away. So again, just be aware that sleepwalking comes into that as well.
Does it talk about prevalence by age, or is it age specific? Or
I don't know.
Anybody for that particular one?
Yeah, I don't know if there is a I don't know what the prevalence is as far as age. I don't think so. I think a lot of sleep terrors have to do with processing. So dreaming itself is, you'll find is your mind trying to make sense of things that that it hasn't been able to make sense of during the day, per se. So you may be sleeping and have a dream of like multiple themes that are not related. They're kind of like, I was in a white room and this and you start looking for themes, and all of a sudden you realize these are kind of, there's elements here of your brain going, where do we put this? Where do we put this situation? So that's why you'll find people PTSD and trauma related having some dream interruption. The brain's still trying to figure out what to do with their experiences, and they may really do a good job during the day of trying to keep that under to maintain their function and not have to deal with that during the day. So sometimes things come out at night, which means some people don't want to sleep at night, right? Because then things come up and they don't want to have night terrors. They don't want to have those type of things. And you'll see patients that'll come in to have so many of them. They're thinking, how in the world, how can you give me a medication so I don't have this, so I can sleep? I'm waking up 3-4 times a night with these things. And so that's where you'll kind of come into as well. So those can all be around the sleepwalking, sleep-related sexual behavior. That's interesting. You will see some complaints of that too. Usually from spouses and different things of like, what's going on. Non-REM sleep account, you'll get into that a little bit too. Breathing related, we got into that already. Seizures, sleep-related seizures. Alcohol-induced blackouts, again, we're looking at some of the differentials. Dissociative amnesia. Panic disorders, medication-induced behaviors, so looking at some of that. Nightmare disorder, recurrent, extended, extremely dysphoric, well-remembered dreams that in efforts to avoid threats to survival, security. So you'll have these dreams that are very vivid. Those continue over a long period of time. Again, not really attributable to physiological effects. So you want to specify it's at onset, associated with sleep, medical condition. What is it that they feel like? If it's associated with a medical condition, there may be certain brain disorders that would cause something like that, those type of things. So in a lot of cases, best thing you can do for this is to be a good historian. Pull out of them details that you can document, so when you do send them to a physician and they request your notes, they get a lot of detail that you may have gotten. Every once in a while I get notes from somebody and I get details I didn't have before, and I'm like, whoa, I didn't know that happened. So yeah, you see some of the differentials as well. Rapid eye movement, sleep behavior, again, it kind of gets into some of that with some of the issues with REM sleep that they have. Again, more doctors are going to deal with that. Restless leg syndrome, urge to move legs worsens during that, and then so this is pretty common. You're going to see this pretty frequently when people have restless leg syndrome. They have problems in their legs, aches, pains, joints. They're constantly trying to move, and it disrupts sleep. It's so difficult. Again, at least 3 times per week for 3 months. And again, that's more likely to be diagnosed by a medical doctor, but you may see it. Substance medication-induced sleep disorders. They're taking Vyvanse, they can't sleep at night, whatever, Caffeine, cannabis, opioid, these are all different indicators, codes. You can get into some of those individually, I'm not going to read them all to you. Other specified insomnia disorders, it gets through all the rest of them. Unspecified, if you don't know, they're just sleeping. And of course, you've got staying up all the time, can't sleep. Other specified, brief insomnia, less than 3 months, but they're having a problem. But you want to make sure it's not related to like some kind of complex grief and things like that as well. Sometimes there's other diagnoses that better fit what's kind of going on. Then you have all the unspecifieds. Unspecifieds are like they don't really meet the criteria fully, but there's really what's going on. That gives you a little bit of an idea. Questions, thoughts, concerns? Yeah.
For these medical disorders, they're in the DSM because they could be comorbid and because they could be caused by
Yeah.
other mental disorders, not because they're a mental disorder.
So when they went to the DSM-5, they went to the ICD-10 codes. The reason they went to ICD-10 is because all the medical professionals were supposed to be going to electronic EMR. And then they're looking for being able to unify these codings. Everybody's operating their own little world. Like your office is over here, Centera systems are over here, Chesapeake General's over there. What they want to do is they're trying to move insurances to a system where everyone's codes go into one database and everybody talks to each other. So everybody knows what an ICD-10 code is. Because for a while under the DSM-4 TR, you had more of a code. You had this 5-digit code. So you had 3 digits with a dot and then two qualifiers. Well, nobody except for us had that system. So like everybody in all of medicine has 10 codes. You go look up the ICD-10 codes, it's going to have tick removal, bitten by squirrel. I mean, there's a code for everything, and then ICD-10s have all this stuff. And then out of nowhere, like we have these 5-digit, what they are, how, and each digit, 32-6-11. The 6 meant that it was this kind of bipolar, and the 11 meant that it occurs this frequently. With it, nobody could read our stuff but us, and so we weren't really playing well with others. Is the way the APA saw it, and so they wrote this manual specifically to say, let's make sure we can all communicate. So that being said, the DSM-5 overlaps when it's saying, okay, sometimes there's psychological reasons people aren't sleeping and they're affected by anxiety or stress or whatever. And then there's medical things too. So you can kind of see, so there's some overlap there. There's things here you're not going to diagnose that a medical professional, when they pull up their codes for narcolepsy, it's in there. And you'll see a chart and it'll have narcolepsy in there and you'll know what it is based on the DSM because it kind of has something to do with psychology. So think big system. That's why it's in there. Although you're not going to diagnose sleep apnea. You're not going to go, really, you have trouble sleeping? You have sleep apnea. You're not going to get that diagnosis. Doctors won't give you that diagnosis. They're going to say, go to a sleep study. You go to a sleep study, and they may not be conclusive. They may say, come back next week and do it again. You sleep in some fake apartment in some building, hooked up to all these machines. I have a friend who's hooked up for 20 minutes. They woke him up. You can go home. Yeah, you have sleep apnea. Like, that was obvious. It was like, it took no time to figure that out. You didn't need to spend any time here longer than that. So like, you'll see those things kind of pop up. But, yeah.
So basically they're there so that we can see how they're connected to the mental disorders.
Exactly. I like how you said it better than me. I went all the way around the block. Came back. Yeah. Any other thoughts, questions? All right, good.